If everybody is here, we'll go ahead and get started. My name is Lucy McGowan. I'll be one of the co-facilitators for this session, the second breakout session with.
Hi, and I'm Kathy Gross. I'll be helping Lucy.
And
I'm John Orsini. I'm sort of a trinket.
A very valued one.
Thank you to those of you who stayed over from the first session. We appreciate it, and we hope that you'll be able to contribute as well and bring us along longitudinally as we discuss this issue. So our goal for this session is we're discussing the assessment of the interprofessional learner from education to the workplace. And this is the meso level, the middle tier of discussion, where we're hoping to focus at the institutional level. So what we'll do first is actually tell you a little bit about what was discussed in the previous session to give you the context for what kinds of challenges and opportunities were talked about at the policy level. And then we'll move through, you have in your handouts some challenges and opportunities that were sent in by forum members ahead of time. Very broad, diverse array of them to take a look at. We'll talk through those to get the discussion going. And then our goal for the end of the session is actually, it's like choosing a favorite child or maybe a least favorite child to come up with the biggest challenge or the most important challenge that you think that institutions could address in this area. And we'll be providing that information to the participants in the fourth group at the end of the day, who will be coming up with strategies to address a challenge at all three levels: policy, institutional, and individual. So what we discuss here today will be carried through and used in the final session. So with that, I'm going to ask Kathy to give a short recap of what we discussed at the macro level, at the policy level.
Thank you. As Lucy mentioned, we talked about a lot of challenges and a lot of opportunities, and we noticed that sometimes the challenges sounded more like opportunities, and the opportunities sounded a little bit like challenges depending on how you phrased the wording. So forgive me if things don't necessarily fit nicely into a category, but just to give you a sense of the types of things that the group resonated with at the policy level. We spent a little bit of time talking about the issue of field placements for students in IPE, the quality, access to, some of the barriers at the policy level that might limit opportunities for students to have that type of experience. We also talked about, at a policy level, a need to more clearly link IPE to the triple aim. We talked about data and what might be available and how we could have both longitudinal data as well as current data that might inform decisions about the importance of IPE. We talked about the possibility of actualizing this conversation that we seem to have at the forum with respect to linked ventures between educational systems and IPE sites where the practice is actually occurring. We talked about data, we talked about that already. Where we ended up in terms of the challenge that group wanted to focus on at the policy level was the issue of how we might work with accrediting bodies with respect to their policies. And we're defining accrediting bodies broadly, not only those that have oversight over educational institutions, but also entities that have oversight over practice components such as the Joint Commission, how we might intersect and work with them to better get traction for high-quality IPE.
So you'll see here on the next two slides on page 4 and 5 of your handout, we got a lot of feedback that could fall into the category of challenges with assessing IPE learners from an institutional level. So there's nothing particularly scientific about the fact that they've been placed here, except for there are possibilities for institutions to address these. So what I'll do is I'll walk through these. Please feel free to raise your hand, turn on your microphone as I go through, and as we walk through numerically these challenges, let's get the discussion going. Nobody has to wait for applause at the end or anything like that. So first, postgraduate tracking. And if I'm not looking, or if one of us is not looking at you, just give us a holler. postgraduate tracking is number one. The second one could be related, low survey response rates from former students. Number three was uncertainty over how much time the learner needs for IPE. And I think that came up earlier from one of our student members as having difficulty integrating IPE opportunities into the established curriculum. Number four was creating IPE learner evaluation tools. Number five, also possibly related, having robust tools that have some of the components that Dr. Norsini talked about earlier, of good tools, accurate, valid, reliable tools for assessing changes to collaborative behavior as distinct from individual behavior. Number six is actually, once you have those tools, getting programs to then use them. And if any of these trigger any thoughts, feel free to offer them up. Number seven, getting funding for development of tools. A lot of times things do tend to get back to money. Number eight was failure to recognize the Hawthorne effect, or the behavior of individuals who are aware they're under observation and may perform differently or be on good behavior, perform how they think the observer wants to see them perform. Number nine, this seemed to be a problem that we discussed also in the previous section, dysfunctional resource-poor clinical learning environments, not having the right environments for IPE learners. Related, number 10, finding IPE clinical placements. Any thoughts on those first? Yeah.
Well, I think that's a really big one right now because providers are under such pressure for, quote, productivity that, this takes a little bit of time. For example, in our institution, we use a lot of community volunteer faculty. And we've been real fortunate in that, but I can see where with ACOs, for example, they're going to be under all of this pressure to produce. And sometimes it's not just the production. We use a lot of community volunteer faculty. When we find that, for example, they're changing, or they're putting in or they're changing their electronic medical record, sometimes they won't take a medical student for 6 to 12 months because they just can't handle that extra bit of work when they're under these other stresses.
Yeah, I want to ask a question about the first two. I co-run a master's program in nutrition that trains people mostly who are going to medical school, so it may not be quite on point, but we try to do postgraduate tracking and we find low survey response rates of former students. But my question would be, if we were able to fully track them and got better response rates, how would that have any bearing on the issue of interprofessional education, which we attempt to do for some purposes? In other words, what would we be doing with them that would bear on that? I don't follow that at all.
I actually think that's an incredibly rich resource if you can acquire it, in terms of evaluating what you're doing against how people ultimately turn out.
So it would be just finding out whether they're working in a setting where they...
No, it's more than whether they're working in a setting. For example, a very simple idea would be to ask them how well prepared they were to work in that setting. How did the training relate to that? How did the assessment relate to it? What were they missing when they got to the work environment that was not in the training?
Okay.
So very simple things like that. There are a whole bunch of more sophisticated things, but even the simple little survey areas will help you, I think, judge the quality of your program and also give you some evaluation of
Okay,
how
so
you
that
can
gets
make
us
it better.
back to 1 and 2, that if you can't track a lot of them, and
Yes.
of the ones you do track, you get very low survey responses. Okay.
Yes.
I'm thinking maybe we should flip the model of that, how we fund education. And maybe we always rely on the clinician educators in practice to volunteer their hours to precept our students. Maybe we should hire fewer faculty on the academic side and funnel some of that money into the practice side, because that's where we really want to make the changes. We can do what we do in the simulation lab, but unless they can transfer those skills out into practice. So maybe it's an increase in your strategic partners, where and who you partner with, where you place your students, working with them, funding more of practice so they have these productivity issues, they can spend time teaching, but doing site preparation to make sure that they are doing team-based care. Maybe there's a policy level thing that could be addressed there, but also flipping it, so because we're always relying on people to help us out in education. Maybe there's too much fluff on that side. We can hire fewer teachers and have more clinician educators. You laugh, Scott.
Sorry, just a quick point of clarification. You were starting to hear using assessment and evaluation, and I like to disentangle the two, assessment of individuals or teams and evaluation of things. So I don't know, this morning was pretty clear it was all about assessment, but we're now straying on to a couple of other points. I don't know if that means anything to anybody.
I'd like to respond to the third one, uncertainty, in that if we're truly thinking IPE and IPC, that there's never uncertainty over how much education we're providing. Rather, it's always integrated throughout the curriculum. And while we need to still educate our clinicians to our disciplines to pass a licensing exam, in most cases, that IPE is integrated throughout, that team-based care and team learning is always there, and that to try to quantify how much time just doesn't seem like we're treating it like a way of thinking that
So-
it really deems.
Can I ask you just a clarifying question? So when you say IP is integrated, that it currently is, or that it should be?
It should be.
It should be.
Yeah.
Okay.
I mean, I think some of us are doing
Yeah.
a good job, but I think that there's a lot of, it's separate for a lot of folks as forced. But when it becomes comfortable, it's not forced anymore. Does that make sense?
Yeah.
Okay.
Yeah, I agree. My comments on the third item. There are several opportunities, I think, for everyone to collaborate together, such as in PBL opportunities and even in basic science classroom opportunities. I don't know what the curriculum is like in different health professions before they get on the floors, but I assume the science is similar, so they can have that opportunity for team-based training when they do the PBLs that's associated with the basic science that they're learning, and so they become more comfortable working with each other before they get on the floors. So I don't know if it answers the question, the uncertainty over how much time, but I think earlier the better.
I just wanted to emphasize, I think, the importance of postgraduate tracking. I think it's something, to respond to the low survey response rate might be one way to look at the policy level, so that perhaps mandate through accreditation processes or whatever that you track your graduate, because you need to be making sure that they're learning and practicing what you're teaching them, or that you need to change the way you teach. So I think it's also, the tracking can also focus on looking at the institutional culture and climate and get feedback on, well, yes, we did learn that course, but we didn't see that in practice. So it's a great way for the institution to learn as well.
I just wanted to also talk about the integration piece. We're trying to do a lot of integration, and I think PBL does that and a lot of places, but some of those activities actually reinforce some roles in ways that are sometimes unintended consequences. And I just wanted to add that one of the things that I think would align the healthcare system priorities, including more clinicians in it, and allowing people to learn about each other, is when you have really not only sort of a shared outcome goal, but also some shared content, and that's QI. There's so much shared content in QI. We have so much redundant teaching of the exact same content. And it really takes some of the role identity issues and social identity issues out of it when you're really focused on those. So I think, and of course, obviously, the healthcare delivery system's interested in that. So I think that's a really powerful tool.
Let me move on. Those are all absolutely fabulous contributions, and I'm going to move on to the second set of challenges quickly, and then we'll go into the opportunities. And I think hearing the discussion, it's very easy to already start kind of going that next step and coming up with opportunities. So hopefully when we get to that, you will offer some of those as well. So the second set of challenges, in no particular order, number 11 is assessing team collaboration in education that closely resembles real practice. Number 12 was focusing on individuals rather than the collective abilities of the group and team. That's something that we were discussing earlier. Number 13 was having inconsistent scoring rubrics from different assessors creates confusion. 14 also related consistent evaluation of learners from all disciplines. Number 15, the comment was made, most health sciences centers only have nursing, medicine, pharmacy, and dentistry. That obviously leaves out a lot of professions.
I think especially for the relevant for the smaller institutions or more focused universities, the development of some kind of interinstitutional network to allow a more accurate picture of real-world practice. And I'm mostly in complementary healthcare fields, so we wouldn't be included in IPE typically. However, in the actual patient model, we very often are. So that, and also we wouldn't necessarily have the ability to connect with institutions or other more conventional universities to have those placements. But if there's some kind of encouragement or opportunities to do so, we would certainly be interested in that.
Number 16 was something that came up in the previous session as well, that dealing with sharing a lack of clinical and administrative data for ease of measurement. Number 17 was measuring the learner in the actual workplace involving patients, so the setting of the assessment. And number 18, finally, longitudinal issues, longitudinal individual assessment of IPE as something that universities, other types of institutions could potentially address.
It's a good list and certainly represents a lot of work that we can do. I'm also noticing that it's fairly focused on a lot of more sort of functional tasks, but doesn't refer as much to a culture shift, a commitment, or a sort of embracing of a change in values that I think is also really necessary here at that meso level. I don't think we're all the way there yet. People in this room are, but.
I wanted to react to number 12 and number 14. Number 12, we sometimes phrase that they're mutually exclusive, and I think it's really both of them. We're probably a lot more familiar with assessing individuals than teams, but I think you have to do both. And number 14, consistent evaluation of learners from all disciplines. That's within disciplines as well. We have a faculty member who on every evaluation writes, "This is the best student I've ever had," and he's been writing that for 20 years. So there's a lot of faculty development and teaching the assessor how to assess.
All right, so I think that already some of these are leading themselves nicely.
We have one more burning comment.
Oh, okay, yeah, absolutely.
You're right. Oh, it is. I think I can reach it. I just wanted to comment that as an RN that has taught clinical to nurses in their first year of core nursing curriculum for a couple of years, and also as a nurse on the floor in the teaching hospital setting,
a phenomenon that I noticed that I think fits in with number 11 is relative to the fact that as RNs, the other discipline that we most frequently interact with is, of course, physicians. And when I'm on the floor with 9 or 10 nursing students, and the residents all come up in that big group, that scary group that goes into the patients' rooms, and my students have to get out, we have missed countless opportunities for one discipline to learn with and from another every time that happens. And I don't think it's isolated to the incidents I witnessed on over 22 years. I don't think it's isolated at all. So there's a big culture shift that needs to occur if we're going to go anywhere with interprofessional education. That's just one example of two disciplines that interact. You talk about real practice and education resembling that. We totally miss the boat on that frequently. So I think it's a great opportunity for improvement.
I was going to say, that's a great segue, I think, for a perfect opportunity. Let's take a look at the list of opportunities on page 5 here. And I think that could potentially fall within one, simulation, well, not necessarily simulation, but actually bringing groups together for learning. But this is simulation to to bring provider groups together for learning. Number 2, stronger workplace linkages to academic institutions for better tracking. Number 3, to develop a depository of toolboxes of IPE and IPP practices and skills. Number 4 was to generate student portfolios that include both self and peer assessment. Number 5, we've heard a lot about this, the potential for joint ventures between educational and delivery systems to the goal of building a better, stronger workforce. Number 6, allowing professions with specific expertise within assessment to guide the other health professions. Number 7, evidence from education can impact collaborative practice and patient outcomes. Number 8, contribute to safe patient care. And number 9, an opportunity to assess the collaborative competency of the health professional. Does anybody want to react to any of those opportunities and tie them to any of the number of challenges that we discussed? And what we're going to do after this to sort of set it up, we have got about 10 more minutes, is we'll circle back around and we'll go back to those challenges and try to develop a consensus on one big challenge to bring forward. So just offering that as you're looking at these opportunities to think of that in mind.
Yeah.
I have something that piggybacks on to one of the challenges that was said before, and it's because I just came off of a leadership development course yesterday, and I think this provides a great opportunity for interdisciplinary mentoring, faculty or staff programs that will help education by having people better self-assess and receive feedback, and then provide a bridge from education into the institution for long-term professional development. And it would also help, if that is a successful program, for retention of people who have made that change as well.
A continuum of opportunity right there.
And if I could add another one. Yeah. I'm also involved in maintenance of certification, and I think getting those principles in quality activities and having people work on group projects for quality is a great way to learn and respect what other people do. The other thing is I think and this is probably more policy, but as workforce issues drive patient care, people are going to be forced into teamwork more. And so I think that will be a push to get some of these programs going, where if you don't need people or you don't understand what people can do, you don't use them. And it can help with burnout. It can help with a lot of other things too.
Picking up on our wonderful kickoff talk first thing this morning about how assessment really signals what's important in education. I think we have a wonderful opportunity as we move assessment more towards looking at interprofessional skills and collaboration to signal through our institutions to our students that the point of the degree you're getting is to become a member of a helping professional focused on the patient rather than to become a member of a professional guild that's mostly about learning how to participate in that cultural sort of power dynamic that each profession unfortunately develops over time. We have a chance to break that up.
I also was, to follow up on that, I think the collaboration, on number 9, collaborative competency of the health professional, we need to incorporate that. It's not just collaboration, but roles, professionalism, communication, teamwork. These are the competencies. And so, yes, they're involved in collaboration, but we need to go beyond collaboration by itself.
I want to respond to number 4. I may be overthinking it more to the individual level, but I think we have to be careful when we ask for deliverables, especially like a student portfolio that's more summative, that while it's a wonderful thing, and I know a lot of institutions are using them, that it is a summative nature, and that the emphasis this morning was placed on really using more formative assessment to guide skill building along the way. And when we add deliverables to the what students are already doing, it sometimes is met with resistance. It's just a thought.
All right. Yeah. Those were great. Now, with those in mind, let's go back to the long list of challenges that we talked about, and I'll review my notes. I hope you guys will do the same, and we'll see if anything stood out. We talked about the pressure for productivity with volunteer faculty, using volunteer faculty, but having a pressure for productivity. There's a suggestion that we are relying so much on volunteer educators. Perhaps we should change that and be funding and investing more time, energy, and money into strategic partners and site preparation of practice locations. I think a couple times we talked about the shift in values that may be needed and the cultural change and tides to really incorporate IPE as a part of institutional and educational cultures, not just as a la carte item that is pulled into the educational system. I think that came up a couple times. I think a couple of times I have noted here yeah.
I just wanted to ask a clarifying question. Are we looking at assessment, the problem, the challenges of assessing learners from the education to practice?
Yes.
That's the
IPE
because we're
learners.
naming a lot of challenges that aren't really related to assessment. So for me, we've lost the assessment piece. I'm not sure if that was our intention.
Yeah, and I'm sure when people were evaluating these or looking at these questions and offering, they may have been thinking about different pieces that make up the assessment process. So, but we are looking for assessment, a challenge related to assessment of IPE learners as well.
Could I please make a recommendation that we take an appreciative inquiry approach, and instead of identifying the challenges, which is what we spend a lot of our time doing around IPE, is maybe highlight one or two opportunities, and then we could think about moving forward, how would that look?
We
Because-
actually, process-wise, that's what the fourth group today will be spending
Oh.
quite a bit of time on, so I hate to disappoint, but your
That
fourth
later.
group will allow you a great opportunity to do
But
that.
I will
And
say, in constructing and defining the challenge, I think that in the previous group, we structured it in a way to hopefully incorporate some opportunities, potential opportunities into the way that the challenge was defined.
So if the greatest challenge, if we're saying that we don't know if skills are transferred from the education side into practice and we can't be there to observe our students, then I would say the greatest challenge is those people in practice who need to deliver care, but yet we're asking them to, maybe we need to ask them to assess their patients. So that's a challenge. So how do we make that work better?
Just want to make sure that we didn't leave out any other large pieces that we had talked about. I think one of the other things that I had seen was a lack of interinstitutional and interprofessional sharing of resources as well, or in some cases a duplication of effort related to QI because of a lack of integrated shared efforts. Is there any sense from the group of what might rise to the top?
We had a suggestion on the floor just a couple minutes ago that seems to make a whole lot of sense. I'm wondering, we haven't had much time to talk about that, but that seems like a very obvious one. Is that a consensus of the group? We should move forward with that as the challenge, or is it like to speak to something else?
Incentives are aligned.
Well, there are a lot of, as we know, a lot of challenges. It's kind of difficult to pick one. I mean,
Yeah.
you were forced
I know.
to. I mean, from my perspective as a researcher, it's about kind of accurate, valid, reliable measurement. You know, we don't have the capacity to do that well at the moment. But that's not just interprofessional education. That's medical education, nursing education. It's health professions education more broadly.
It seems to me one of the real challenges, and you highlighted it, is that there's no opportunity, or there's not sufficient opportunity to observe trainees in the workplace where these sorts of skills are needed and where you can assess them before they go into practice. At this point, we're stuck either assessing them in very early, not very high fidelity kinds of situations, or in practice, that clinical piece is missing. So it seems like the creation of those opportunities is the real challenge. The creation of the opportunity to get the trainee into a place where you can observe them with patients in the workplace before they're done, before they graduate and move on into practice. Did I get your point?
I think it's more that observation is key, but I think you've got to triangulate evidence. You know, I mean, yeah, you want to see them in action in the workplace, but you know, there's the Hawthorne effect that can happen. We know we change our behaviour when we're being watched, but I think going for a sort of more more kind of triangulated approach would be useful.
Yeah, I think that there's no question that faculty development needs to occur because in all these devices, it's not really the form that people are filling out. It's the faculty as the assessment device. And so lots of work needs to be done with the faculty, both in terms of assessment and culture. So you're absolutely right in terms of putting that piece up front as you make the transition. But you have to get the kids into a workplace first before you can do any of that kind of stuff.
How are we doing on time? Okay. Back in the back.
Turn the other mics off, please, if they're on.
Oh, there we go. Just from I guess, a pragmatic standpoint, I recently ran into this issue that I think goes to some of the other points that some of the other participants mentioned. From an assessment standpoint, one of the issues I've really had recently is getting student buy-in. And so the surveys have been not really filled out completely. They don't necessarily take it very seriously, and I think that goes back to what one of the other participants mentioned, which was culture. and culture from a student standpoint, culture from faculty standpoint, and I think there needs to be a lot done to sort of remediate the faculty and the students in the importance of this issue. They just, as hard as we tried to get them to understand why this is needed, when it came down to doing the completing the assessment tools, the commitment just wasn't there.
And part of the reason is that there are no consequences for either the students or the faculty. And we can talk about culture all we want, but until there are consequences, it really doesn't seem to me to be possible to get anybody to buy in to any of this, as anybody with teenagers knows.
And I would also add, when there isn't student buy-in, it's usually larger. It's that there's not institutional buy-in, and it goes even beyond faculty. It's our administrators at our collective universities. When they're not putting resources and time for folks to get this going, then that trickles down to students not buying in. It's a systems issue.
All right. So thank you all so much for your contribution. I'm sorry we're going to have to wrap it up, but we're going to try and put everything together into a cohesive package and move it on to the next group.
And
Thanks all.
if you would please leave your handouts on the table so we can recycle them to the next group.